Okay, so we'll start out with the first presentation on the validity of reporting of interventions delivered during the intrapartum and postnatal period by Kate McCarthy. Kate is an independent consultant and doctoral candidate in epidemiology at the City University of the New York School of Public Health, where she is a global health fellow at CUNY's Center for Immigrant, Refugee, and Global Health. Until quite recently, she was a staff associate at the Population Council, and she was also, besides ICM work, she was involved in research related to gender, adolescent, sexual, and reproductive health, and in this case, measurement of the quality of maternal and newborn health services. And with that, I'll turn it over to Kate. I will say, so presentations are going to be about 10 minutes long. We have 5 minutes for questions after that, immediately after each presentation. And I would suggest that we use those questions for kind of quick questions of clarification and save the bigger picture questions for the panel discussion.
Good morning, everyone, and thank you. I'm happy to be here speaking about work we've done over the past several years regarding maternal health indicators. I'm also speaking on behalf of my colleague Anne Blank, who couldn't be here today. So surveys such as DHS, MICS, and other survey programs provide information on where labor and delivery took place, the type of provider who attended the woman, and whether a postnatal care check took place. But until relatively recently, there's been little to nothing on the content or quality of care received by women. So we sought to address the question, can accurate information on the care received by women be provided during labor and delivery in the immediate postnatal period within the first hour of birth or during a return postnatal visit, be obtained in a survey format. I'm going to speak about 2 studies today which addressed these questions. They're both published in the supplement. The first addresses labor, delivery, and immediate postnatal care. It uses exit interview and household follow-up data in Kenya. So this study provides information on not only immediate recall accuracy, but how accuracy changes over time, 13 to 15 months after the birth. The second study addresses return postnatal care. So these are women who are returning to a health facility for care for themselves or their newborns between 24 hours or 10 weeks after birth. And this study uses exit interview data in both Kenya and Swaziland. This country is now known as Eswatini, but I'm going to refer to it as Swaziland in this presentation, as that was the name at the time of the study. So I'm going to just briefly describe the basic study design in Kenya. So women who consented to participate in the study were observed by a trained provider by a third-party observer at baseline using a structured checklist. And this was compared to women's report of care received at exit interview on facility discharge. And this provides information on their immediate recall accuracy. Women were then re-interviewed in their homes 13 to 15 months after birth, and again asked the same set of questions in the exit interview questionnaire. And this was compared to the baseline observation to provide information on recall accuracy at delayed follow-up, so 13 to 15 months after the birth. We also conducted qualitative interviews with a subsample of women, 20 women, to get insight into how they understood certain terms and key concepts in the questions that they were asked. And finally, we compared recall accuracy at the 2 time points to see whether there was significant decline in recall accuracy. And there were 606 women who participated in the baseline survey, 515 at follow-up, which is the retention rate of 85%. So this slide lists aspects of care in the intrapartum and immediate postnatal period that this study sought to assess. These are the overall major categories and give some examples. It's not an exhaustive list. There in total were 34 indicators of maternal health that were tested at both baseline and follow-up. We also tested indicators of immediate postnatal care for the newborn. But for the sake of time today, I'm just going to be speaking about the maternal health work, and I refer you to the supplement. So what aspects of care can a woman recall 13 to 15 months later regarding labor and delivery? So the 4 indicators listed here on the slide, whether a support person was present, the main provider during delivery was a nurse midwife, whether the woman received a cesarean operation, or whether the infant was low birth weight, were the 4 out of 34 tested maternal health indicators, which met either moderate or higher accuracy at both time points. So just to orient you briefly to the notation in the table, under the individual accuracy heading, a plus sign indicates moderate AUC, which is greater than 0.6 and less than 0.7. Double plus is our highest criteria, which is greater than 0.7. Under the population accuracy heading, a plus sign indicates whether or not our population level criteria were met, an inflation factor between 0.75 and 125, which means it was neither substantially over or underestimated from the true observed prevalence. A dash sign would indicate it wasn't met. And for each of these 4 indicators, we saw that there was no significant decline from baseline accuracy in the AUC, suggesting that indicators that were recalled with high accuracy at baseline tended to maintain their recall accuracy at follow-up. But again, just noting that this is a very small number out of the number tested. So now moving to immediate postnatal care for women. This is received within the first hour of birth. These are 6 indicators here listed on the slide. Most of them are related to different health checks for the mother in the first physical exam after delivery, such as whether the provider looked or asked about bleeding, checked the woman's blood pressure, did a perineal exam, took her temperature, checked to see if the belly was becoming firm, or firmly massaged the abdomen to help the womb become firm. And this table presents results for each criteria at both baseline and follow-up. And the main take-home message is that none of the indicators met both our validation criteria at either time point, and there were no indicators that met high accuracy individual reporting at baseline or follow-up. So in general, this period was not reported on well. And the qualitative interview data gives some insight into why this was the case. I'm just going to read this illustrative quote. The woman says, "You know, that time after the birth, I was overexcited. So after the cesarean section, I was happy to see my child like this, and I gave God my thanks. So I cannot know, because once I saw the baby, I was tired. So whatever happened after that, I don't know." And we found this type of quote to be generally representative of women's feelings of exhaustion, of emotional high intensity. Women might be experiencing pain, and together this made recall accuracy particularly difficult. We also found that women who had a cesarean section birth, in particularly, were not able to recall accurately interventions received in that first hour after birth. So now moving to study 2, which assessed postnatal care at a return facility visit, so between 24 hours and 10 weeks after birth. This study relied on secondary analysis of the Integra Initiative, which was a joint project led by LSHTM and Population Council and other partners, designed to assess integrated family planning, sexual and reproductive health, and postnatal care services. For our purposes, we pooled data from 12 health facilities in Kenya, from 2 provinces, and from 8 health facilities in Swaziland from 8 different regions. There were 545 women in the analysis in Kenya and 319 in Swaziland. And the study design was the same as the baseline study in the Kenya intrapartum care study, where women were interviewed at facility discharge in an exit interview questionnaire, and this was compared against the observer report of what happened. So these are the aspects of care that we sought to assess for maternal care measured at a return postnatal care visit. They related to aspects of the maternal physical exam, whether she was counseled about danger signs or given advice, return to fertility, as well as family planning counseling. So there were 13 indicators related to maternal care in Kenya that we sought to analyze, and 15 in Swaziland. Okay, so here are 6 indicators related to physical examination of the mother. And under each country heading, to the left of the bar, the symbols, a double plus again indicates high accuracy for the AUC, whereas a plus indicates moderate. An NA indicates that there was insufficient variation in the the survey data or sample size to be able to assess that indicator. To the right of the bar, under the population level accuracy, again, a plus indicates whether or not our criteria was met, whereas a dash indicates that it wasn't. And all the way to the side of the table, the country's initials are listed if both criteria were met to a high level in that country. So here we see that all indicators, apart from the anemia check in Swaziland, met either moderate or high individual accuracy for a postnatal care. And there were 4 in Kenya and 3 in Swaziland that met our criteria to a high level. There were three indicators here which relate to health counseling for the mother. So whether the mother was asked about excessive bleeding, whether the provider discussed danger signs after birth or STIs or HIV. All of these indicators met our criteria to a high level in Kenya, whereas they only met the criteria for population accuracy in Swaziland, suggesting that the false positives and false negatives were kind of balancing out at the aggregate level for these indicators in Swaziland. And finally, there were 7 indicators related to family planning, counseling, and return to fertility. And of these indicators, 3 in Kenya, whether the provider discussed birth spacing benefits, return to sexual activity, or a family planning method, and 1 in Swaziland, whether the mother received any modern family planning method, met our criteria to a high level. The bottom 2 could not be assessed in Kenya because of sample size issues. So now I'm going to summarize what we've really learned across these 2 studies. We found that really, in general, there were few labor and delivery care indicators that could be reported with high validity. And these ones that were performed particularly poorly seem to be in this immediate postnatal period, and our qualitative interview data provides some insight into why that was the case. We did find that those that were reported with high validity at baseline generally maintained their recall accuracy over time, but again, this was a pretty small number. In contrast, women seem to be able to more accurately report on maternal postnatal care at a return facility visit, which makes, sense, as women might be, not as fatigued and distressed in pain in this kind of setting. The same trend was found for newborn indicators, which I didn't discuss today, but in general, mothers were better able to report on what happened to their newborns at a return visit rather than in that first hour after birth. We found that 10 out of 13 indicators in Kenya and 5 out of 15 in Swaziland met our criteria, and 5 were the same in both countries. So this is encouraging for the return postnatal care indicators. At present, there are no content of care indicators for what a mother receives during a postnatal visit in the core DHS, so suggesting that in the future these might be promising to track. And I just want to acknowledge the funding for this project, and as well as our colleagues who contributed to the work, Charlotte Warren, who is here today. So thank you very much.
Thank you, Kate. Any questions?
Okay, I'll be brave and ask a question.
Yes, John.
So the data that you've collected, would it allow you to look at if a woman was asked A, and was she also, if she recalls being asked about A, does she also recall being asked about B, and look for those correlations so you could identify in the true sense of an indicator, which one thing could be asked that might be representative of a suite of things she may have been asked?
I think we've been starting to see bigger picture trends like that emerge from the data as we replicate it in additional countries, which we're continuing to do in our current grant. So, like I mentioned, certain things tend to be not recalled, like timing of interventions, the sequence of interventions, particularly received in that period right after birth, tend to be not recalled. But in contrast, we see that physical things that happen to the mother. So if they're actually being touched to have their blood pressure checked, their weight taken during a more relaxed setting, seem to be better recalled, which makes intuitive sense. So we're starting to see those kinds of trends, but I think we're hopefully be able to explore additional disaggregation as we can pool our studies in the future.
Thank you. That was really great. I'm just actually curious as to, particularly on the counseling and counseling on danger signs and complications. Did you also capture whether they had complications or danger signs? Do we know whether there was any correlation between an experience of a complication and a recall?
That's a great question. So there's two studies that I'll talk about to answer that question. The first is the intrapartum study, where women were asked, did you experience these symptoms of a complication? And we found that those were not well reported. I think it falls into that category of right after birth. Women tend to over-report kind of experiencing symptoms. In the postnatal care study, where women are asked about counseling, did the provider discuss this list of danger signs to look at? In that study, we were not able to look at whether that woman also experienced a complication because we don't have that data on what happened at birth. We just have the postnatal care visit. It would be interesting to see that, but the validity data we know about how women can report on symptoms of a complication would make me think that it might be tricky to disentangle that, unless it's another kind of way of getting at whether they actually had a complication. But that's a great question.
In a study we did in Bangladesh, we found that it was more on community-based births. Women remember much better things they had control over, like putting the child to the breast, than things that were done to them. Did you find the same?
I think often, particularly in the qualitative work, when a woman may have received an intervention, she might not have known that she received it. For example, if the standard of care in that facility was to inject a uterotonic into the IV line, and she wasn't told that was happening, then she wouldn't have known that it happened. So yeah, things that the woman was not made aware of, that she wouldn't know to look for, were difficult to understand and recall.
Any last question? Okay, well, thank you very much.
Okay, thank you.